This is the Fertility Friday podcast, episode number 60. Welcome to the 60th episode of the Fertility Friday podcast. Thank you for joining me today. I'm Lisa from FertilityFriday.com, and this is your source for information about the fertility awareness method and all things fertility. If you've been enjoying the show, I would love it if you take a moment and leave a review and a rating on iTunes. It helps the show move up in rankings. It helps more people to find it. And of course, I'd like to say a special thank you to all the listeners who've left reviews already. I read all of your reviews, and I really appreciate you taking the time to let me know how I'm doing. And if you enjoyed today's episode, please stop by the show notes page and leave a comment. You'll find all the episodes at fertilityfriday.com/podcast. You can find me on Facebook at facebook.com/fertilityfridays with an S, on Twitter at fertilefriday, and make sure to sign up for my email list. Just head over to fertilityfriday.com and you'll never miss an episode, and you'll be the first to know when I release a new blog post. So as many of you know, I also recently created the Fertility Friday Facebook group. So just head over to fertilityfriday.com/community and you'll be redirected to the group. And in 2016, I'm actually going to be opening up my schedule to see clients. I'm so excited to be offering fertility awareness support and education. So I have a limited number of spaces available, only 2 spaces per month to be exact. So if you're just learning about the fertility awareness method and you want someone to walk you through the basics of charting, so to do a detailed introductory session and a few follow-up sessions, or even if you have a little bit of experience under your belt, but you're still learning and you have a few questions, I'm developing a couple of programs. So shoot me an email at info@fertilityfriday.com and we'll figure out if we're a good fit. And we can always schedule a 15-minute chat to figure that out. And in today's show, I'm very excited to welcome my guest, Dr. Katherine Sharif. Dr. Sharif is a professor and vice chair of the Department of Medicine at Thomas Jefferson University in Philadelphia. She is also the director of Jefferson Women's Primary Care. Dr. Sharif is an internist, and she became interested in polycystic ovary syndrome in the 90s when she was studying insulin resistance. She started treating women with PCOS, and around the year 2000, she established the country's first academic program for polycystic ovary syndrome. Besides PCOS, Dr. Sharif her interests include menopause and hormone therapy, the effect of omega-3 fatty acids on heart disease in women. She also published a textbook on women's health in 2008 and a medical handbook on hormone replacement therapy in 2013. So she's been extremely busy. And in today's show, we'll be talking about PCOS and how Dr. Sharif treats women with PCOS and helps them to conceive without fertility drugs. So without further ado, welcome to the show.
Thank you very much.
So thank you so much for being here today. I've been looking forward to our interview. So I did give you a bit of an intro, but why don't you take a few minutes and to fill in any of the gaps and introduce yourself? And also, I'd love to know how you ended up being interested and taking such professionally in PCOS.
Yes, well, thank you. And thank you for giving me a platform to talk about something that I love. So I'm an internist, not a gynecologist, and I barely remembered Stein-Leventhal syndrome from medical school when I was a third-year student. So after I finished my internal medicine residency, I was matched with a research mentor who was looking at insulin resistance. And there was a group of women, I was looking at African-American women with elevated insulin levels who also had enlarged hearts. And there was a subgroup that had high testosterone levels. And I thought, oh, how interesting. I mean, insulin's bad for the heart, testosterone's bad for the heart. And this group turned out to be Stein-Leventhal or polycystic ovary syndrome. So my interest really came from the medical side of things as opposed to the endocrinologic side as opposed to the gynecologic side. And then this was 1995. I had no idea how many women had polycystic ovary syndrome and that, in fact, we were seeing them every day and that we just didn't know we were seeing them. And especially in internal medicine, where we tend not to ask people about their periods or their pregnancies and so on. And it became very interesting to me because an internist has to be comfortable with ambiguity and comfortable with treating a lot of different areas of medicine and putting them together and not necessarily being an expert in any one thing. And it turned out that the women with PCOS were seeing dermatologists because of hair on their face, hirsutism or hair loss. They were seeing gynecologists for irregular periods, fertility doctors for infertility, seeing other doctors for diabetes, and so on. So it really appeals to me because it covers so many systems.
Mm-hmm. Well, and I have to say, I'm not so familiar with internal medicine. So maybe you could tell the audience members what is an internist and what is internal medicine? How does it differ from your typical run-of-the-mill doctor?
Sure. So, internal medicine, we are known as primary care doctors today. We are like family medicine doctors, but we don't see children and we don't do OBGYN. Um, we Most of our training is in the hospital and in intensive care units. And so most of those people go off to do specialties like gastroenterology and cardiology. And but a small group of us do general internal medicine, and that makes us like kind of like family docs.
Okay. And so it's interesting how your interest in PCOS began. And it's also interesting what you said because given the variety of different symptoms that women have, of course, they do end up seeing a ton of different doctors because no one's putting them together. So how has this knowledge informed your practice when you find that women are experiencing symptoms and have PCOS?
I'll tell you, it's made me a much better doctor because it, early on, I realized that there was something right in front of me that I wasn't seeing. And I wasn't seeing because I wasn't asking the questions. And um, it made me, it just made me a better clinician and diagnostician and able to put all kinds of things together and not just polycystic ovary syndrome. And it's interesting. I started off and still am in a primary care practice for women or, women's health, but not an OBGYN practice. And it turns out that this is by accident. Polycystic ovary syndrome is a paradigm of a women's health issue. So when people say to me, well, what's a women's health doctor? Because you mean you're not a gynecologist, but you do pap smears? And what I would say is that women's health is the intersection of sex hormones, the so-called sex hormones like testosterone and progesterone, and where they intersect with the rest of the body, the heart, the lungs, the kidney, the liver. So the so-called sex hormones, the way we conceptualize them is they have an effect on the reproductive organs, but they absolutely have an effect on every other part of your body. For example, testosterone causes the arteries in women to constrict, to vasoconstrict. We want them to be dilated. And when your arteries are vasoconstricted, that's when you get hypertension. And so testosterone is not good for your arteries if you're a woman, but it's good if you're a man. So another interesting thing is that estradiol, our most important estrogen hormone, makes you retain sodium, makes the kidney retain sodium. And progesterone, in contrast, is a natural diuretic. So we need to look at female physiology and understand it in the context of sex hormones. It really has changed my life.
I absolutely love the way that you explain that. One of the topics that I've addressed on the podcast is why the menstrual cycle is important to overall health. Because just like you said, we often think of female hormones just to do with the plumbing, just to do with our uterus and our ovaries. But as you mentioned, all of these hormones have a profound impact on our entire body functioning. And as a woman, it's so interesting how our reproductive systems and hormones are viewed separately to the rest of our bodies when they're all intertwined. So I absolutely love that she said that. So for our listeners I have talked a little bit about PCOS on the podcast, but for the listener maybe who's listening for the first time or maybe not too familiar with PCOS, perhaps you could just give a brief overview of what it is and maybe what symptoms women typically show. I know it varies, but some of the symptoms that women typically show if they have PCOS.
Sure. So the symptoms usually include irregular periods, and by irregular, we don't mean that it comes 28 days this month and 32 days later next month, but maybe varying from 2 weeks to 5, 6, 7 weeks. Some people don't get periods for months. So number one would be irregular periods. Number two would be, do you have high testosterone in your blood, or do you have signs of high testosterone, such as hirsutism, so it's too much hair on your face, or you're losing hair, what we would call alopecia. That's another sign of high testosterone. Do you have severe acne or cystic acne? Do you have acne in places where women or girls don't usually get it? Let's say across your chest or your upper arms or on your back or on your jaw instead of on your cheeks. So because you do have high testosterone, the follicles in the ovaries get confused, and generally in polycystic ovary syndrome, the ovaries are normal and they want to release eggs every other month and take turns, but they can't in the environment of too much testosterone. And that's where the infertility comes from. And it's relatively easy to treat. If you take away the testosterone, the ovaries know exactly what to do. And that's one of the beautiful things about PCOS. Now, about cysts on the ovaries, some doctors will argue that unless you have polycystic cysts on the ovaries, you don't have PCOS, and I couldn't disagree more. Many of my patients with polycystic ovary syndrome do not have cysts on their ovaries, and the cysts can come and go. So basically, they were follicles that wanted to become the egg of the month. They filled up with fluid. They're no more than a centimeter, which is about half an inch. And they are ringing the ovary. They're on the edges of the ovary. So they have a characteristic sign on ultrasound called string of pearls. And again, I don't believe that they are necessary to the diagnosis.
Okay. Well, and as you were talking, you mentioned high testosterone levels. So that would indicate, obviously, that the hormones are imbalanced. And so do you know what causes that? What some of the reasons are why women are experiencing this high level of testosterone?
Yes, so the testosterone comes from the ovary. Now, I just said that the ovary was normal, but the ovary is reacting to something else called insulin resistance, which I know many of your listeners have heard about. So the way insulin resistance works is when you eat, you need a little bit of insulin to metabolize your food. And then the insulin quickly breaks down, disappears because your food is metabolized. When you are resistant to insulin, you are resistant to very small amounts that the pancreas releases. So you need more insulin than someone who's sensitive to insulin. When you have higher levels of insulin, they hang around longer, and then they bind to the ovary and they tell the ovary to make more testosterone. So then the ovary the ovary, which was doing just fine and making a little bit of testosterone, which we need, now starts making a lot of testosterone, and you get the secondary effects. So that's where the testosterone comes from.
Well, that's really interesting that the insulin resistance is what interferes with the normal, what the ovaries are supposed to be doing, and then makes them produce more testosterone. And so then for a lot of women, obviously, just like you mentioned, so women who might have this facial hair situation and they go to the dermatologist and the dermatologist isn't connecting the dots, or they have acne, same thing, and they're not connecting the dots. So what are some of when it comes to diagnosis and treatment, how do you diagnose women? And what would you say are some of the reasons why women aren't being diagnosed by these other care providers?
Well, the reason they're not being diagnosed by other people is because if you don't think of it, then you don't see it, or if you don't know of it. So when, we have a saying in Philadelphia, when you go to Midas, you get a muffler. Midas is a muffler company. And if you go to a dermatologist and the dermatologist is not familiar with PCOS, no matter how many people they're seeing with acne, they're not going to see PCOS. So when I have spoken to dermatologists, they have changed their practices. And when I've said, when you see someone with severe acne or hirsutism, there's no other reason to have hair on your face except if you have high testosterone levels or they're balding, please consider polycystic ovary syndrome in your differential diagnosis, what's causing this, and then refer if the person has PCOS. So you have to know about it to see it. So when other doctors are educated, they refer. Sometimes women are not diagnosed by gynecologists because the gynecologist won't mention it, and the woman or the girl will say that they have irregular periods. The gynecologist will place them on the birth control pill and say, this should take care of your periods. Or often they'll say, oh, you have polycystic ovary syndrome. That's where you make too much testosterone, your periods are irregular. The treatment for it is the pill, and when you want to get pregnant, come back. And again, I don't think that they realize that diabetes is a very big part of this and that it needs to be nipped in the bud and treated right away. It's frustrating sometimes.
Well, yeah, because just like you mentioned, the pill is the standard treatment protocol for when PCOS is identified. So maybe you could elaborate a little bit on why that's obviously, as you mentioned, diabetes, insulin resistance. So maybe you could elaborate on that a little bit, talk a little bit about the relationship between the insulin dependence and why women with PCOS are at an increased risk for diabetes, and also why the pill isn't actually addressing anything in this scenario.
Good point, right. Um, well, I'll start with the pill. So if you want to give someone regular periods or periods every 3 months, or you want to manipulate the periods, the birth control pill is an easy way to do that. And so you will have a fake period every month or a fake period every 3 months if you take, 3 months worth of the pill and skip the placebo. So when you give someone high doses, when you give them the birth control pill, the levels of estrogen in the birth control pill are 5 times our physiologic levels. It's not a replacement. It's a it's a super dose. And the point is to put your ovaries to sleep and take over menstruation. Well, those high levels of estrogen, they increase something called sex hormone binding globulin. Sex hormone binding globulin binds testosterone, and so there's a lot less free testosterone to circulate. That's why your skin can look better when you take the birth control pill. So it deals with irregular periods and it can help acne, hair, and the loss of hair. However, it does absolutely nothing for insulin resistance, as you alluded. And I think that goes back to women's health, that like, what is women's health? Is it just, it's this, the way we have this schizophrenia in medical school. There's the reproductive part and there's everything else. And that's how we're taught, and we never bring them together. If you have diabetes, it could be because your ovaries aren't working. And this is what makes it's much more complex and understanding of diabetes, and it's what makes life more interesting for us as physicians. So the way the reason that the pill doesn't help the insulin resistance is that it's a lot of estrogen and it can make your skin better and give you periods. Now, the way insulin resistance is tied to diabetes is like this. Almost everybody with type 2 diabetes, they started out it's not that they have too little insulin, it's that they made too much insulin. So let's say you get your period when you're 13. Your periods are always irregular. You start to gain weight, or you're not really overweight, but you always have weight in the middle, or you're overweight and a lot of your weight is right in the middle. That's the weight of insulin resistance. So you have very high insulin levels, and because you're resistant to insulin, the insulin goes over to the ovaries. It tells the ovaries, make a lot of testosterone, and you get all the other symptoms. Then the insulin happens to be a growth hormone. And if you are a fetus, you're tiny and you need a lot of insulin to grow into a baby. If you're a toddler, you need a lot of insulin to grow up into an adult. But adults don't need a lot of insulin. So you so you've got this growth hormone that you're producing because you need a lot of it to metabolize food, but at the same time, it's making you gain weight, especially in the middle. And then the problem is anyone who gains weight uh, becomes more resistant to insulin, which means now when they eat, they need to produce more insulin to get the same job done. So over the years and years and years and years, since you're 13 or whatever, your pancreas is working overtime and producing very, very, very high levels of insulin to get the same job done. And then one day the pancreas just poops out and it can't produce enough insulin to metabolize your food. And then your doctor measures your blood sugar and says, wow, your blood sugar is 250, you're diabetic. And you say, well, where did that come from? And they say, well, you got to lose weight. But what they don't understand is it started years and years and years ago. And, diabetes is an epidemic in the United States. It's considered 6 or 7% of the population. And it's an emergency. And it's not just because people gained weight in their 20s. It starts a long time before then.
Mm-hmm. Well, and I think one of the things that is what you've alluded to and what you're saying is that it's a process. It's like a disease process that is going on in the background and it's just going on unchecked. And one of the things that I always talk about when it comes to the birth control pill is that, just like you had said, I love how you said that, what is women's health? So it's so interesting because it seems like women's health is symptom management. It doesn't seem like it's actually addressing what the problem is. So whenever a woman has a menstrual related, reproductive related concern, the birth control pill is often the go-to. But whatever the actual disease process that's happening in the background, it's still happening, but the birth control pill allows those symptoms to be masked. And so, I'd love to get into a little bit about how we can move forward, and when women have PCOS, what are some of the things that we can do to help them and to, as you mentioned, improve their fertility without relying on drugs. But before, I would just love to hear your thoughts on that whole idea that while they're put on the pill, it seems like this disease process, this insulin resistance, is just operating on the background. And when the doctor says, when you're ready to get pregnant, just come back to me, then what is that doing to her fertility? Women are often on the pill for 5, 10, 15 years, 20 years.
It's true. I really like the way that you put that this disease process is going on in the background. And like if you knew that, if you were a physician and you knew that there was a disease process going on in the background and you knew how devastating type 2 diabetes can be, how could you possibly put someone on the pill and not at least refer to someone else who can help, like an internist or a family practice doctor or generalist, someone who can help to prevent diabetes. So it makes me crazy because I think, well, do you do not understand physiology or you don't care? That's what I think on my bad days. Well,
not to mention, how does that help women address their fertility? Because there's this idea that, it's this idea, and it drives me crazy, that if you have problematic periods, you have heavy periods or whatever, heavy periods, painful menstruation, for example, absent periods, they're just not there. You're not menstruating regularly. You go 5 months without a period, and this is like happens every now and then. So you go to the doctor, and the solution is, okay, go on the pill. So then how do we just assume that when you want to get pregnant, you're just going to go off the pill, and whatever it is that was causing your periods to come every 5 months or causing you to have devastatingly painful periods, or maybe whatever it is, like no cervical mucus or whatever the case is, we're just going to assume that that's going to be just fine.
exactly. Exactly. It is so short-sighted. It's kind of like you're in my office now. I will deal with this problem now. Goodbye. And short-term, short-term solution thing is covered. Um, it's very frustrating. It actually makes me pretty angry.
Mm-hmm.
It makes me angry. I will see people maybe who didn't come to see me for PCOS because I am an internist, so I see all kinds of people, and they'll say, "Yeah, no, I've never had irregular periods." And okay, well, when did you get your period? Well, I was 13. And were your periods regular? I'm not sure, maybe not. Oh, but I had really horribly painful periods, right? They probably had endometriosis. Um, Again, another underdiagnosed problem, which makes me crazy. But they, so they say, well, the doctor put me on the pill when I was 15, and now, I want to come off the pill because I'm 35. But I've always had regular periods. And they have no idea whether they have regular periods or not. And you're right, the same problem that got them on the period, nothing changed. It was masked all this time. And so then they have to deal with all their feelings of frustration and anger about finding that they're infertile when they're 35 or 30 or 28, whatever it is, because no one ever discussed it with them.
Mm-hmm. Well, and so let's get into a little bit of hope for women who are listening. So, for anyone who's listening, you went through some of the symptoms. So, for a woman who isn't sure, we kind of laid the framework, like a few things. If you have hair in places of your body where you shouldn't, cystic acne or acne in other places, if you have irregular periods, those are some of the flags for PCOS. And when you work with clients and you identify these issues, maybe we could speak to how you help them to address the insulin resistance and what are some ways that you help to reduce their testosterone levels so that we kind of get rid of the process that's going on and help the ovaries to work the way they're supposed to.
Yes. So my favorite way of treating PCOS is to help my patients become sensitive to insulin, meaning they would require less insulin in order to get the job done. And at this point, we can't fix your genes. We will be able to soon, maybe within the next 10 years, but not right now. So what can we do to make your body more sensitive to insulin? And the way I conceptualize it, it's five things. Number one, you eat fewer carbs. And when you eat carbs, you get a bigger spike of insulin, a bigger response of insulin than when you eat proteins and fats. For example, if you eat, say, three boiled eggs, that would be 200 calories of really good quality protein and fat. And you would get a little spike of insulin after eating it in order to metabolize it. If you eat 200 calories and it happens to be half a bagel, that's like pure sugar. And so you get a very big insulin response. So to lower your insulin levels, you need to eat fewer carbs and fewer calories just in general, but mostly it's carbs. Secondly, another way to make yourself insulin sensitive is to get more muscular. So when you go to the gym, don't work out on the elliptical. I mean, you can do it for a while, but don't let that be your main thing. You should really work on weight training for bigger muscles. And so in general, this is why men are not as overweight as women are as a group. Just because they have bigger muscles, it makes them more sensitive to insulin. Thirdly, you need to sleep 8 hours a night. Now I know you can't, but yeah, that's
Because
a
I'm a
very
new
tough
mommy.
time. You're a
Yeah.
new mom, brand new mommy, 3 months, you're not sleeping 8 hours a night. But you have to make it a priority. It's not negotiable. I mean, after the baby is a little bit older, it really is non-negotiable, and you cannot shave time off your sleep. If you don't sleep 8 hours, you are going to be resistant to insulin. Fourthly, after diet, exercise, and sleep would be taking medications like metformin. and not everybody can tolerate it, but it's a wonderfully safe drug that I've been using for 20 years for PCOS. And it makes you sensitive to insulin in several different ways. And remember, when you're sensitive to insulin, you need a lot less insulin to get the job done. If you have less insulin, you're less likely to gain weight because it is a growth hormone. If you have less insulin, less of it goes to the ovaries and you don't produce so much testosterone. And then your ovaries can kick in and do what they're supposed to do. And then finally, so if you can't tolerate, metformin isn't the only game in town. And if you can't tolerate that drug, there are other medications. And finally, there's supplements. And there are many supplements that make you sensitive to insulin. My favorite is vitamin D.
Wow, that's interesting. Maybe you could talk a
Yeah.
little bit about that.
Vitamin D is such an interesting vitamin. It's a hormone. It's a very complex molecule. And it has a very strong association with fertility and a strong association with insulin resistance. And it also strengthens the immune system. It tamps down the autoimmune system. So people who are vitamin D, who don't have deficiencies, are less likely to have an autoimmune disease. And it also, a lack of vitamin D is strongly correlated with ovarian cancer, breast cancer, and colon cancer, and in men, prostate cancer. So it's really an amazing vitamin. I measured almost 1,000 women in my practice, consecutive women, a few years ago, just to see how many were deficient. And of those 1,000 women, by deficient, I mean your levels are less than 35. There were only 2 women who had levels above 35. 2
Out of
out
a
of 1,000.
thousand.
Yeah, just 2. It is, we do live in the city. We're more of a northern latitude, but, it probably explains a lot. Vitamin D suppresses, I'll give you an example. It suppresses renin. And if you have high renin levels, you can have hypertension. So why do Black women in Philadelphia, this is a group I studied, why do they have so much hypertension, and why is their hypertension is so bad? And it's possible that it's related to vitamin D levels, and you can't get it from food. You get very little from the sun. It's hard to get when you're running to your car every day, back and forth. And the darker your skin, the less you're going to get. So that's something that needs to be studied.
Well, that's interesting to me, given that I live in Canada. So in our northernmost lovely country, and as a woman of color as well, I'm
Right.
so aware, and I always find it really interesting. We always talk about flu season in September as if it's a season. And hello, and I don't know about where everyone else is living who's listening to the podcast, but in September and October, that's when the sun goes away. So imagine that everyone gets sick.
Yeah, right. Right. I'll tell you that the countries with the worst vitamin D deficiency are Scandinavia and Germany, not surprisingly. And I mean those are the ones we know of. I'm sure there's, I'm sure all the northern countries have very low vitamin D levels. It's so important to take it with food because it is fat soluble. So a lot of people take vitamin D level, or they'll have been told to take vitamin D, and I say, well, why aren't you taking it now? Well, it never made my levels go up, so I guess it just doesn't work. That's not true. You got to take it with food. The vitamin D that's over the counter in the United States and Canada, all of it is vitamin D3, whether it says D3 on it or not. There's a prescription vitamin D2, which is 50,000 units, that is sometimes prescribed for low vitamin D levels, but it's actually not that well absorbed and not that well converted to vitamin D3, which is the one we need. So everybody can get vitamin D, and they should get it dirt cheap. You shouldn't be paying a lot for it.
Well, that's,
Oh,
yeah.
can I tell you something else?
Oh, please.
Vitamin D is stored in fat. So if you have more fat cells, you are distributing you're storing the vitamin D in that fat. And so another reason people may say it's not going up is not that they're not taking it with meals, but they're just not on enough. probably most people need around 5,000 units a day. But the current recommendations in the US, which I don't know what they are in Canada, the current recommendations are 400 units, and which is a
Nice.
joke. And then there was a huge argument when some researchers recommended that it goes up to 1,000 units a day.
Okay, that was going to be one of my next questions, which is, how much should we be taking, especially if we're living in these northernmost places. And so that's really interesting. And it's so refreshing. So you are the second medical doctor that I've had on the podcast. And it's so refreshing to speak to a medical doctor that is talking about dietary changes and exercise first, talking about medication, but also talking about supplementation in a very specific and helpful way. So I really appreciate you, and I hope that you
Thank you.
inspire other medical doctors to kind of open their minds and open their eyes and see that it's not just about the prescription. I think it's hard for doctors, though. I don't think doctors mean harm. I think that it's a real thing. When you go into your doctor, they only have a couple minutes with each patient. It's just the way that it is, the way that the system is. I'm not exactly sure how it is in the States, but in Canada, I mean, the doctors mean well as well, but you have a limited amount of time with your doctor, and they usually have figured out what they're going to do with you within the first 30 seconds after you've opened your mouth.
I know, I know. I think it's similar here too, and we have very limited time, but I do the best that I can. But it's exhausting. It is exhausting, and I've had to teach myself a lot about nutrition, and I certainly don't trust what I learned in medical school. And we didn't have the internet when I was in medical school. Now I can look things up fairly rapidly, but I used to go to the library every week and read for hours and just try to get a handle on things. So I think it is difficult being a doctor, but I also think doctors could try a little harder.
Well, I think it's something to be said for anybody who is a professional in any area. Whatever it is that you learned in school, the longer that you practice, the more that that's going to be out of date. So
Right.
their professional development is something that everybody needs to do, regardless of what area they're in. And so it would be a good idea for doctors to make sure they're up on the latest information, even if it's just going to a few conferences in specific areas or something like that. You know what I mean?
Right.
Um,
Or
so
at least keep an open mind. They're so quick to shut people down and go, no, I don't think that's true. Um, but the thing is, why don't you just keep an open mind and then make up your mind later, but without shutting people down right away?
hmm Well, and so the treatment protocol that you described, so with your clients that you see with PCOS typically, because of course women who are coming to you are going to want to know, okay, so I changed my diet, I cut the carbs, and from what you said, having a good amount of healthy protein and fats with your meals is a good idea. So those types of things. So they implement the protocol. How long before they're going to see changes to their menstrual cycle and an improvement in their symptoms?
Well, usually I see changes within 2 or 3 months. So by the time I see you again in 3 months, often see people in 3 month intervals, at least in the beginning. By the time I've seen you, you've had 2 or 3 monthly periods. It's amazing. It's remarkable.
Wow. Yeah, because I mean, for especially for women who I think it's especially challenging. So in my realm, so women learn about the fertility awareness method, they get so excited. And the ones that are brave enough to go off the pill and face whatever period issues that they had before, then they're expecting to see this perfect chart. When you read the books about fertility awareness, they talk about, okay, you're going to have your menstruation, and then you're going to have some dry days, and then you're going to have cervical mucus, and then you're going to ovulate, and then you're going to have, 12 days, and then you're going to have your period. And so then these women get off the pill, and they're just waiting and waiting and waiting and waiting and waiting. And sometimes their period doesn't come for 5 months, 6 months. So I think it's really reassuring that by making these changes, it's really impacting the root cause, which is the testosterone hormone affecting the ovary function.
Exactly. Exactly. And um, with the first time somebody got pregnant when I prescribed them metformin in 1995. I almost fainted because I knew theoretically we're lowering insulin, which will lower testosterone, which means your ovaries will start working. And the people who figured this out were the Italians. They're on the cutting edge of so much research. So, but I still couldn't believe it. I thought it just can't be that easy. And it is for most people. Yeah. So it's sad when I see people in their late 30s who didn't get the proper treatment, or people who have failed fertility treatment but have not, or fertility drugs but have not tried more simple things. It's very sad.
So do you get specifically fertility clients in your practice, or does it just kind of happen that do people come to you specifically for fertility, or does it just kind of happen that way?
No, in the beginning it was all sort of by accident, and then now I see a fair number of people who travel for fertility.
Okay, and so then for women who are struggling with fertility and just are thinking about whether they should be going to the assisted reproductive technologies route, what has been your experience with that? Have you seen women who have gone that route already without success, who've done IVF treatments and then come to you afterwards?
Yes, I have many times, and most of the time they can get pregnant with a variety of insulin sensitizers. Sometimes they have a condition called late onset congenital adrenal hyperplasia that looks like PCOS that no one has diagnosed. And the treatment for that is very, very low dose steroids, a safe dose of steroids. It's just steroid replacement. And then it's that simple.
So if there were any, I don't know, I don't think there's any doctors listening to the podcast, but you never know.
No,
So
you
for
never
you
never
never
know.
know.
It's true.
So for any physicians, health professionals listening to this podcast, what would you want them to know about PCOS based on our conversation today and your experience in practice?
Well, I'd like them, I don't, for any kind of physician, anybody, a surgeon, anybody, consider the fact that your patient might have polycystic ovary syndrome and refer them to somebody who's familiar with that, whether it's an endocrinologist, a reproductive endocrinologist, or even an internist who is an expert in the area. You have to think of it or else you won't see it.
Mm-hmm. So really put it on your radar, understand what the symptoms are, and stop thinking of that person as just that one symptom type of thing, I would imagine.
Exactly, exactly. This isn't just cystic acne. There is a reason people have cystic acne. I, it didn't, I didn't realize this until recently. There is not a single woman who's been on Accutane for acne. This is the heavy duty drug Accutane. There's not a single one who I've seen for this who didn't have PCOS, but I didn't know that starting out.
Wow.
But if you have acne that bad, there is a reason. It isn't just like, oh, bad luck.
I think that's really powerful information to know that, because I think we all know on some level acne has to do with hormones, but they just kind of say, oh, it's overactive hormones. And perhaps during your teen years, that's just normal or whatever. And so many women are put on hormonal. One of my college roommates was put on hormonal birth control for her acne. And that in and of itself is a huge topic. I don't know if you want to speak to that a little bit, but women who are put on hormonal contraceptives at age 14, 15 because of acne and not even for birth control.
Right. Well, I'd like to hear about your experience of this. For me, it worries me. Your breast development isn't finished, as well as other things. Your brain development isn't finished. We know that when you give the birth control pill, it doesn't just hit your reproductive organs, it's soaking you in hormones. So what does that mean for the rest of your life and for your development?
Well, absolutely. And I had Dr. Jerry Lynn Pryor on the
Oh
show.
yeah,
I
I read
have,
her book. She's brilliant.
yes. Oh, I was so excited to interview her. So at the time of this recording, actually, her interview will be released this Friday. So for the
Oh
listeners,
good.
we're recording this about a month ahead of when I'm releasing your episode. But so when I interviewed Dr. Jerry Lynn Pryor, we talked about the menstrual cycle, and I've talked about this on the show before. So a woman's menstrual cycle takes several years to mature. So in addition to the fact that she is not mature, her body, her brain, her breasts, her menstrual cycle is not mature either. So it takes several years of menstruation before a woman's cycle becomes kind of that regular, robust, becomes ovulatory. And so when you start taking the birth control pill in the middle of it, then once a woman goes off of the birth control pill, her wherever her menstrual cycle was in terms of the stage of development, it starts there and it continues. So it still has to fully mature. And that's actually terrifying if you think about it in those terms.
Yes. Yeah. And what does it do to your brain? Our brain soaks up hormones. It's
Yeah.
yeah, boy,
And
that's
those are not our hormones. Those are
no,
synthetic hormones that are not our hormones. So who knows what they're doing to our brain. I don't want to think about it.
exactly. I know, right? Yeah.
So as we get towards the end of the show, I have a few final questions to ask you. But before I get into those, I just wanted to know your thoughts on the future of PCOS diagnosis and treatment. I mean, where it's going and maybe where you hope it's going.
Sure. Well, one thing that's been encouraging to me is the fact that many obstetricians in the US have accepted that metformin is a safe drug to use at least in the first trimester of pregnancy. And but although they still give me a very hard time. Often a woman will call me and say, okay, I finally conceived on metformin. I'd like to stay on it for at least the first trimester. The OB says, no way, go find another OB. I'm not going to do this. Or would you please call him? Invariably, it's a him. And explain to him why it might be a good idea. And but I don't get as much pushback as I used to. And so that means there's a growing awareness, even though the Italians, as I said, figured this out in the 90s and metformin became available in this drug in this country, in the US, in 1995. So there is more awareness, but I think that the most awareness is going to come from women themselves, or the most change is going to come from women themselves. And for advocates for women with polycystic ovary syndrome, like PCOS Challenge, which is based in Atlanta, Georgia, it is the sheer force of these women who are demanding that their doctors learn more about it, or they will leave and go to doctors who already know about it or are willing to learn. So I'm encouraged that education has increased. I think the biggest change will come from learning more about insulin resistance and how do we fix it? Can we fix it genetically? And I think that'll change everything.
Okay, and to follow up on what you said about metformin during the first 3 months of pregnancy, so is that something that you would recommend to help with the insulin resistance, or is that something that you would not recommend because of any dangers to the baby?
No, I would strongly recommend metformin actually during the whole pregnancy. There's some evidence that it improves lactation. One third of women with PCOS cannot lactate, one third can lactate poorly, and one third can lactate normally. And it looks like from the studies that women who use metformin can lactate. So this is if they use it for the whole pregnancy, and it makes sense because if your you can have very high estrogen and progesterone levels during the pregnancy, but if you have high testosterone levels, that doesn't allow growth of the ducts, the milk ducts. So that's one thing. Secondly, there are some studies that show that metformin doesn't decrease the risk of miscarriage in PCOS. But in my experience, 20 years experience, the women who have had it at least for the first trimester are less likely to have miscarriages.
And my
which is
understanding is during pregnancy, you're more naturally insulin resistant. Anyways, I did a really
yes.
interesting podcast episode with Lily Nichols, and she's a nutritionist who specialized in the area of gestational diabetes. It was an extremely interesting episode where she basically talked about she recently wrote a book, and the name of the book is Real Food for Gestational Diabetes.
Ooh,
Yes. And so her approach is to help women with gestational diet. Well, first of all, to identify it early. So to really do that screening within that first 3-month window to see who is more likely to have it, but also then to address the condition when possible with food first,
yes.
as opposed to relying solely on medication. So it was a really interesting podcast, and I'll link to it in the show notes. So my question to you then is, have you seen a link then between women who have PCOS and women who have gestational diabetes in their pregnancies?
Of course, so many go on to develop gestational diabetes, and being on insulin will reduce the incidence or reduce the risk of developing gestational diabetes. Um,
Being on insulin or being on
on
metformin?
being on
Okay, just double checking.
being on metformin reduces the risk, and it's always important to remember that metformin can interfere with vitamin B12 absorption and who knows what else. So it's really important to be on multivitamins anyway, even if you're not trying to conceive. But I feel so strongly, of course, pregnancy is an insulin resistant state, an especially insulin resistant state. When women take metformin, the babies are smaller, like in a good way, meaning they're
Mm.
not babies that are too big when the moms take metformin during pregnancy.
Okay, well, I have a few final questions to wrap up our interview today. So here goes. What would you say is the most important thing that a woman should know when she's trying to get pregnant?
She should know you mean whether or not she's PCOS?
Yeah, you can take it however you see
Okay,
it.
there are two things that come to mind immediately, and that would be her nutrition, her nutritional state is, and number two, because that's what the baby is going to be receiving, and number two would be her thyroid. What's her thyroid function like?
Absolutely. And what would you say is the biggest myth about PCOS that you'd like to see corrected?
The biggest myth is based on obesity and fat shaming. There's a lot of doctors who do fat shaming, and that it's there's a lot of contempt for women who are overweight from physicians to women in the US. I don't know if it's similar in Canada, and that it's not anyone's fault, quote unquote, that they are obese, and that we have to if you can't get that out of your head, you can't really take good care of a patient.
Mm-hmm.
So
Yeah,
I'm really sick of the fat shaming.
well, yeah, absolutely, because then you're not actually trying to treat the person. You're just sitting there thinking like, "Oh, it's your fault that you're sick," which is
Yeah,
skinny
right.
people get sick too.
Right. And the rude things that physicians say, like just push away from the table, just eat less, just whatever. Um, you can't do that.
Yeah, absolutely. And what would you say is the biggest myth about fertility that you would like to see corrected or that just irks you in general?
Well, I guess this is from my point of view as an internist who takes care of people with PCOS and finds them failing fertility treatment or doing things they can't afford. It really irks me that fertility specialists are so narrowly focused on drugs, and that they seem to not be interested in the big picture, and that it's so much more than fertility drugs.
Yeah, absolutely. And final question of the day. I love asking this question. So for a woman who's listening who is currently on the pill, she doesn't want to get pregnant now, but she's thinking about getting pregnant maybe in the next 2 to 3 years. What advice, if any, would you give to her?
I would tell her that, okay, you have 2 years to get into the best metabolic shape of your life. So I want you to examine how you eat, how physically active are you? Not saying you need to go to the gym 4 days a week by any means. Do you sleep 8 hours a day? Are you taking care of your teeth? Do you take supplements? You have 2 years, so let's make the most of it.
Yes, I think that's amazing words to end on for today. Oh, so thank you so much for being here today. I really appreciate you taking the time to share your knowledge and your experience. It was just a pleasure talking to you, and I love it. You're my second medical doctor on the show, and you're just such an inspiration. So I really appreciate that. So for all of our listeners who are wanting to know more about what you do and maybe contact you, where do you practice again? What part of the world are you in?
I practice in Philadelphia, Pennsylvania at Thomas Jefferson University.
Okay, so for any of our listeners in Pennsylvania, how can our listeners get in touch with you and find out more about you?
Well, they can go to our website, go to thomasjeffersonuniversity.edu, and they can just put in my name, Katherine Sherif, Sherif. That's how you spell my last name. Or you can call us at 215-503-4779, and we do long distance consults if you can't get to Philadelphia.
Okay, wonderful. Well, thank you again. It was just a lot of fun talking to you today.
Same here. Thank you so much. Thank you for all the good work that you do.
Oh, thank you so much. Thank you for listening. If you enjoyed today's show, please share it with a friend. I'd love to hear your thoughts on today's show, so head over to the show notes page and let me know what you found most helpful from today's episode. So you'll find the show notes for today's show at fertilityfriday.com/60, so the number is 60. You can find me on Facebook at facebook.com/fertilityfridays with an S, on Twitter at Fertile Friday, and if you enjoyed what you heard today, then come over and join the Facebook community. So just head over to fertilityfriday.com/community and you'll be redirected to the Fertility Friday Fertility Awareness Facebook group. Also, don't forget to stop by fertilityfriday.com and sign up for the email list so that you'll never miss a podcast episode or a new blog post. You'll be the first one to know. And if you've been enjoying the podcast, please look for it on iTunes and leave a 5-star review so that more people can find the show. And of course, leave an honest review. I do read them all, and I really appreciate you taking the time to let me know how I'm doing. And as I mentioned at the top of the show, I am opening up my schedule in 2016 to see clients. Yay! I'm so excited to be offering fertility awareness support and education. So as I mentioned, I do have a limited number of spaces. So if you're interested in learning about the fertility awareness method, I have a program for providing that detailed introductory session as well as some follow-up. And also if you're more at an intermediate level, I can certainly do bit of an overview as well. So shoot me an email at info@fertilityfriday.com so that we can figure out if we're a good fit, and we'll set up a 15-minute Skype chat to do that. And also, if you have any ideas for a future podcast episode or if you have a guest suggestion, also shoot me an email at info@fertilityfriday.com. That just helps me to keep making awesome shows for you. So I appreciate all of you for taking the time to tune into the podcast. So whether you're on the go, commuting to work, whatever you're doing, I really appreciate you taking the time to listen to the show. And as always, until next time, be well and happy charting.